Hello everyone. Today we're going to learn about drugs affecting the respiratory system. So in this topic we have two separate lectures. The first one we're going to learn about drug for asthma, and then the second one we're going to learn about allergic rhinitis and cough. Okay, learning objective for today. So what we expect the student is by the end of the lecture, students should be able to list the drug used in the treatment of asthma, the mechanism of action of this drug, and their potential adverse effect. And in some of the drug, we also want the student to learn about the pharmacokinetic features of this drug. Aspect to be discussed in the lecture, we're going to learn about a brief review about pathophysiology of asthma, and then the different classes of the drug used in asthma, including beta adrenoceptor agonists, methylxanthine, antimuscarinic, glucocorticoids, antileukotriene, and mast cell stabilizer, and the adverse effect associated with the use of this drug, and the route of administration of this drug. Okay, just a brief review about asthma or definition of asthma. Asthma is a chronic inflammatory disease of the airways. It is characterized by episode of acute bronchoconstriction or recurrent reversible airway obstruction. It's often associated with this sign and symptom. So you can see shortness of breath, cough, chest tightness, wheezing. Okay. Why asthma makes it hard to breathe? So as you can see here, we have a cartoon diagram comparing the normal bronchial tube from a healthy individual and an inflamed bronchial tube from an asthmatic individual. In healthy individuals, you can see that the muscle around the bronchial tube are relaxed and the tissue is thin, allowing for easy airflow. However, in the asthmatic individual, you can see that the bronchial tubes are tightened and thickened, and the air passage become inflamed and fill up with mucus. And you can also see that the diameter has greatly reduced, making it difficult for air to move. On this other side, you see a staining of the airway section from normal and asthmatic individuals. So you can see here in the asthmatic individuals, you have mucus hyperplasia and hypersecretion, and the thickening of the basal membrane and smooth muscle volume is also increased. What causes and trigger asthma? So there are different causes and triggers for asthma, ranging from the pet dander, from cat, dog, and whether dust mite, cockroaches, pollutants, pollen, and also in some individuals, stress, emotions, and exercise also triggers asthma. Okay, this is a process underlying the cellular and molecular mechanism driving the pathophysiology of asthma. So what happened during inhalation of allergen, the airway epithelial cell, the first cell that comes into contact with the allergen, will produce various cytokine and chemokine that attract the recruitment of various inflammatory cells to the site of inflammation, for instance, into the lung. So what happened? These cells become activated and they then secrete various inflammatory mediators listed here that trigger these responses in the airways and also the lumen. So what happened here, you can see that it triggers bronchoconstriction or bronchial hyperactivity, plasma leakage, edema, and also the epithelial shedding or subepithelial fibrosis. Okay. In addition to that, upon activation of dendritic cells migrate to the T cell area of draining lymph node, and they interact with the naive T cell to promote T cell differentiation. And this then promote T cell survival, and then B cell, which is the cell that responsible in producing antibody, produce IgE antibodies, and these IgE antibodies will bind to mast cell and ready for future interaction with allergen. So re-exposure to the same allergen in future will result in the activation of adaptive immune responses that amplify and drive asthma pathology. So the three characteristic or common characteristic of asthma, so in airway inflammation, bronchoconstriction, and bronchohyperactivity. So where it constricts too much and too easily. Okay, so for asthma treatment, the aim or the goal of the treatment is to terminate bronchospasm by relaxing the airway smooth muscle using bronchodilator, and also to prevent bronchospasm. This is for long-term control of asthma, to reverse and prevent airway inflammation, and we use anti-inflammatory agents. Okay, so we're going to learn about the drugs for asthma. The first one would be bronchodilators. Okay, the first one is SABA and LABA, which is a beta-2 adrenoceptor agonist. The mechanism of action directly and selectively act on beta-2 adrenoceptor on the airway smooth muscle and causes relaxation or dilatation of the bronchi. We have two different types here, the short-acting and long-acting. Example of the short-acting is salbutamol. For the long-acting is salmeterol. For a quick relief of acute bronchoconstriction or acute asthma attack, it's always salbutamol because of the rapid onset of action of this drug for within 5 to 30 minutes. While salmeterol has longer duration of action for about 8 to 12 hours, salbutamol only 4 to 6 hours. And all asthmatic patients should be prescribed with a SABA inhaler. Okay, for the salmeterol, usually it is used in combination with an asthma controller medication, for instance, inhaled corticosteroid. More information on SABA and LABA. So, beta-2 agonists have no anti-inflammatory effect and should not be used as monotherapy for patients with persistent asthma. So it has no anti-inflammatory effect, which means that it does not resolve inflammation. It only provide relaxation or dilatation of the bronchi. Okay, patients taking salbutamol should not take beta blockers, propranolol, because beta blockers have an opposite action to this drug and can cause airway to narrow. Okay, so propranolol is a non-selective beta blocker, right? So it can inhibit beta 1 and beta 2 receptors. As you all know from the previous lecture on sympathomimetics, beta 2 activation is important for airway relaxation. So if an asthmatic patient is taking propranolol, it's going to worsen their asthmatic condition because beta-2 relaxation will be blocked. So patients taking salbutamol should not take beta blockers. Adverse effect associated with this drug: tachycardia, cardiac dysrhythmias, okay, and use in caution or extra monitoring for patients with heart disease. And the common one is beta-2 mediated skeletal muscle tremor, and tolerance due to regular use of this drug, in which the beta-2 adrenoceptor function undergoes desensitization during persistent exposure to the agonist. Okay. Okay, the next drug that is also under bronchodilators is anticholinergics. Example, ipratropium. So mechanism of action for this drug: it inhibits the M2 receptors on the airway. Therefore, when it inhibits the muscarinic receptor, it inhibits bronchoconstriction, and therefore it promotes bronchodilation. Okay, this is the pharmacokinetic information about the drug. Onset 30 minutes, duration about 3 to 5 hours. This drug is not recommended for routine treatment for acute bronchospasm in asthma, as its onset is much slower than SABA. So remember, salbutamol is always the first-line therapy for acute asthma attack. This drug may be useful in patients who are unable to tolerate a SABA or in COPD patients. It also works in combination with SABA for the treatment of acute asthma exacerbation in the emergency department. Adverse effect is very minimal. It's only dry mouth or xerostomia, and also cough. Okay, the next class of drug is methylxanthines. Example is theophylline and aminophylline. Mechanism of action of this drug: it inhibits the phosphodiesterase enzyme. which raises the intracellular CAMP, which is the second messenger involved in the activation of receptors. So it also an adenosine receptor antagonist. Oral sustained release therapy in patient that is not responding to beta-2 agonists, in addition to steroid, and also it is used for severe acute asthma or status asthmaticus through IV. And here is what the definition of status asthmaticus. And it is well absorbed in the GI tract and metabolized by the enzyme P450 in the liver. Okay, these are just some pharmacokinetics of the drug, but all you have to remember is the mechanism of action and the example of the drug at this stage. Okay, methylxanthine have been largely replaced with beta-2 agonists and corticosteroid due to its narrow therapeutic window. Adverse effect profile, so you can see here there are various adverse effects associated with the use of this drug, and also has many unwanted drug interactions. So here you can see what I have written here, that plasma concentration of the drug might be increased or decreased depending on the drug that is co-administered together, or if the patient is also taking the drug on top of methylxanthines. It can, because of its because of this unwanted drug interaction, monitoring of serum concentration of the drug is very important when theophylline is used chronically. So just now we have covered all the drugs that is focused to terminate bronchospasm, so bronchodilators. Now we're going to look at the drug that is used for long-term control of asthma and to prevent the airway inflammation. We call it anti-inflammatory agents. Okay. So the first one is glucocorticoids, or also called a steroid. So we have a different formulation, so or route of administration: inhaled, oral, and intravenous. And these are the example. So mechanism of action: glucocorticoids inhibit cytokine and leukotriene production. So if you remember the diagram about the pathophysiology of asthma, so you have cytokine, leukotriene that mediates airway inflammation. So glucocorticoids inhibit the production of the cytokines and leukotriene, and therefore it inhibits airway inflammation, and it can also reverse mucosal secretion and reduces the hyperactivity of the bronchiole. Mind you that glucocorticoids are not bronchodilator, so they cannot relax the airway smooth muscle. It is a drug of choice for long-term control in patients with any degree of persistent asthma. Must be taken regularly. Okay, so who are they? Patients who require regular bronchodilators should be considered for glucocorticoid treatment. For severe patient, use higher potency inhaled glucocorticoid budesonide. So the first one, you can consider giving them inhaled beclomethasone. During acute exacerbation of asthma, which may require intravenous hydrocort and oral prednisolone, and during status asthmaticus, which is require medical emergency. Okay, in this patient, what they require is oxygen, inhalation of salbutamol via nebulizer, intravenous hydrocort, followed by a course of oral prednisolone. Additional measures, if required, nebulized ipratropium, intravenous salbutamol or aminophylline, and antibiotics if there is an infection in this patient. Alright, it is important to note that for glucocorticoids, especially for drugs that delivered through inhalation, a lot of fraction that inhaled glucocorticoid is either deposited in the mouth and pharynx or swallowed. Only 10 to 20% of the dose inhaled that is not swallowed is deposited in the airway. So if inappropriately inhaled, systemic absorption of the drug could occur, and then it could lead to many adverse effects. Okay, that is why it is important to make sure that the drug is being delivered properly and the inhaler is being used properly. So this extra slide is just to educate you on the different inhaler that are available: dry powder inhaler and metered dose inhaler. So with the metered dose inhaler, it has this spacer which contains small particles that can readily travel to small airways. So it is used to decrease the deposition of drug in the mouth and pharynx, and useful in children and elderly. So it improves the delivery of the drug to the lung. Okay, so with dry powder inhaler, the method that you or the technique that you inhale will be of the drug will be different, quickly and deeply, and there is no spacer and no chemical propellant to help facilitate delivering the drug to the lung. Okay, while for metered dose inhaler, you have to inhale slowly and deeply compared to dry powder inhaler. Okay, so that is just some information for you to know. Alright, so glucocorticoid, what are the adverse effects associated with the use of glucocorticoid? So for inhaled glucocorticoid, the commonly associated adverse effect is oropharyngeal candidiasis, and also called as oral thrush, and hoarseness of voice or dysphonia, and dry mouth. If it gets into the systemic circulation after long treatment with glucocorticoids, it can lead to all these side effects. So you can read here, and also one of the common one is Cushing syndrome. So this is what happened in Cushing syndrome. Usually the inhaled corticosteroid does not really associated with this side effect if the drug is delivered properly and accurately and did not get into the systemic circulation. Okay, so the next anti-inflammatory agents, we have cysteine leukotriene receptor antagonist. So it is a selective antagonist of the cysteine leukotriene 1 receptor. So if you refer back to the one of the slide about the pathophysiology of asthma, we have leukotriene as one of the inflammatory mediators. So this drug blocks the receptor on which leukotriene binds to. So it blocks the cysteine leukotriene 1 receptor, and therefore it prevents its action or its effect. So here the mechanism of action, and this is a further explanation to that. Okay, it's given orally in combination with inhaled corticosteroid, or when LABA inadequately effective, and it is approved for children as young as 12 months. Adverse effect associated with this drug is headache, gastrointestinal disturbance, and also Church-Strauss syndrome, inflammation of the small and medium-sized blood vessel. Okay. Alright. So the next one, which I think would be the last drug for anti-inflammatory agents, is called mast cell stabilizer. The example is sodium chromoglycate. So the sodium chromoglycate, the mechanism of action is to inhibit mast cell degranulation, which occurs after exposure to specific antigen. So when it inhibits the mast cell degranulation, it inhibits the release of mediator called histamine from the mast cell. So if you can see here, once remember the pathophysiology of asthma, we have IgE being produced, and then IgE bind to mast cell. IgE is cross-linked on the mast cell surface, and upon re-exposure to the same allergen, this trigger mast cell to degranulate and release its content, and one of the important content is histamine, which is the inflammatory mediators in asthma. Okay, sodium chromoglycate is used for prophylaxis during allergen or exercise-induced asthma, but not during acute asthma. So acute asthma attack is always bronchodilator, salbutamol, and also for allergic rhinitis. So we're going to learn about this later in the next lecture. Short duration in action, taken on daily basis 3 or 4 times daily. Therefore, because of this, it affects the adherence and limits its use in patient. Adverse effects are minor because it is poorly absorbed, only cough, dry mouth, and throat irritation. Okay guys, this would be the summary of the drug used in asthma. So we have learned about bronchodilator and anti-inflammatory. So I have summarized here bronchodilator. We have PAM, beta-2 agonist, anticholinergic, and methylxanthines. The example of the drug and mechanism of action. All you need to do is probably you could just fill it up more with what are the adverse effects associated with the use of this drug. And then you have anti-inflammatory, SLAM, glucocorticoid or steroid, cysteine leukotriene receptor antagonist, L, leukotriene, L, mast cell stabilizer, M. And then the example and also the mechanism of action. And the same thing also, you could fill it up with the adverse effect associated with the use of these drugs. Alright. An extra slide for you that I captured from different textbook that I used for this lecture. So this would be summary of drug use in asthma, and then albuterol is actually salbutamol. Okay. Okay, and I guess that's it. So anything that you are not really sure and need further explanation, feel free to email me. My email address would be at the front page of this slideshows, and also you can always come and see me in my at my office. Thank you and happy studying.